Iliac vein lesion and ovarian vein reflux are two entities, different separately from each other. The situation has been changed in the last decade with the publication of studies reporting case series of the combination of ovarian vein reflux and iliac vein lesion. At the time, the main clinical endpoint was chronic pelvic pain. The paradigm shift was reflected both in changes in terminology as well as in the therapeutic approach. The term pelvic venous disorders was proposed to describe various disorders of the pelvic veins. A new classification of pelvic venous disorders was proposed, which include the following three domains: symptoms, varices, and pathophysiology, with the pathophysiology domain include anatomical and hemodynamic and etiologic features of the patient disease. The SVP classification is complementary to and should be used in conjunction with the SEEP classification. When creating a treatment plan, it's important to note that many patients with pelvic venous disorders have multiple venous abnormalities. And so, effective treatment for them is defined by symptomatic improvement, and we should tailor the treatment for each patient. A critical question to consider: what is the first intervention to be done for patients with combined lesions? Is it embolization of the ovarian vein, or stenting of the iliac vein lesion, or simultaneous lesion? To answer the question, let's first review the current evidence in the research. Let's start with the current evidence research that support embolization of the ovarian vein first. Findings from that study reported that when analyzing response to treatment, those with patients with combined ovarian vein reflux and iliac vein lesion, they reported that only 9 out of 94 patients responded to ovarian vein embolization alone, and only after ovarian vein embolization, only 9 out of the 94 patients responded to embolization alone, and the rest of the patients responded after stenting. I want to share a case study supporting this finding. This is a 25-year-old female patient with no history of DVT, complaining of pelvic pain and coital and postcoital pain, having prolonged menstrual cycle, unremarkable venous duplex of the lower limb, and transvaginal duplex revealed dilated ovarian vein. The direct CTV showed a moderate left non-thrombotic iliac vein with a dilated left ovarian vein, 10 millimeter. We did embolization first, and after the left ovarian vein embolization, the patient did not feel much relief of the pelvic pain. Afterwards, we did a follow-up CT after 1 year, showing that we have obliteration of the left ovarian vein and significant non-thrombotic iliac vein lesion. So, the plan for stenting of the common iliac vein. The second intervention for the patient was performing stenting of the left common iliac vein as shown, starting by the initial venography, pre-dilatation, and then stenting, and the final venography. To conclude, the left ovarian vein embolization provided limited relief from chronic pelvic pain, but stenting the left common iliac vein resulted in significant pain relief. Now let's shift to focus on the current evidence of the research supporting stenting of the iliac vein lesion. The data suggests that pelvic venous outflow lesion should be treated first, and that ovarian vein reflux should be treated only if symptoms persist. In other words, in case of significant iliac vein lesion, the ovarian vein is acting as a compensatory escape vein rather than the primary pathologic vein. I'd like to share another case supporting this finding. 35 years old female patient with marked post-thrombotic iliac lesion, a dilated right ovarian vein measuring about 10 millimeter, and the left ovarian vein measuring about 8.5. We did the first intervention for this case was performing stenting of the post-thrombotic iliac lesion as shown. Initial venography, pre-dilatation, left common iliac vein stenting, using wall stent, ending with this final angiography. And the follow-up CT 17 months after iliac stenting showing patent lumen of the stent, and the ovarian vein have significantly reduced. The size of the right ovarian vein became 6 millimeter instead of 10, and the left became 4 instead of 8.5. And the patient has significant pain relief. In conclusion, in case of a combination of significant iliac vein lesion and ovarian vein reflux, treating iliac vein lesion alone may be sufficient in most patients, especially with more severe iliac vein stenosis. And if the symptoms of the disease persist for 6 months or more, the ovarian vein embolization should be performed. Further, multicentric randomized trial are needed, and thank you for attention.